Thanks for asking me along this afternoon, this evening even. My name's Carmel Wilkinson. I am a specialist nurse in multiple sclerosis. Now, I started my career in the RVI in 1990, so I've been an MS specialist nurse for almost 25 years, following, obviously, your little girl roots, you know, where you cut your teeth in nursing. I worked in care of the elderly for a little while, and then I worked on neurology, and that's where I fell in love. It was a passion. And during that time on neurology, I was there for 9 years. I knew where I wanted to be and what I wanted to do. So I've been there for 5 years now, South Tyneside and Sunderland a Foundation Trust. And I am currently the only MS nurse for the whole of that trust. We have nurses over at the RVI and we have nurses at Middlesbrough. But it's quite a sort of a nuanced and very specialist area that's really quite tricky to recruit for as well, because it's there aren't many neurological units. Well, we have one ward in Sunderland. It's really difficult to get people in. Anyway, that aside, my love is multiple sclerosis. It started when I was much younger. My mum was diagnosed with MS, and the way in which she was managed absolutely throttled me. I just thought, I can't possibly let anybody else go through what she went through at diagnosis. The absence of support, information and guidance. So that was kind of my driver. And that was whilst I was working in the neurological unit as well. So I kind of, like I say, fell in love with MS itself, because you're drawn to kinds of people when you come into nursing, and specifically in neurology, there are a lot of long-term conditions. So MS is actually the largest cause of disability in the young adult. So diagnosed roundabout, well, anywhere. I've had a paediatric caseload in Newcastle for aged 6 onwards, but it tends to be diagnosed sort of mid-20s to your mid-30s, when you're at the prime of your life, when you're forging your career, when you're making life decisions like family, etc. So it's one of those conditions that's really quite a big, like I say, the biggest cause of disability in the young adult, neurological disability that is. So I've come to talk about, and I'm no expert, all right? I am no expert in menopause. This is why it's just multiple sclerosis and menopause. I have so many crossovers. It's really important for me as a nurse to educate my peers, but also my patients, to make sure that they can have that information to empower them to go through to GP. Much the same as any support group. This is one of the reasons why I'm here, but also one of the reasons why I follow the group as well. So what I'm going to sort of just briefly go through, and I really don't want this to be formal. I would really like you to interact if you don't mind, and stop me, ask questions. I'd love some discussion points as well, because there are some things that are possibly not that relevant, and you can just do that, move on, or say just interrupt me, like I say. So I'm going to talk a little bit about what MS is and how it happens, when it happens, go through the stages of women's health in the context of MS, and what the impact of the menopause is on MS, and just briefly go through it. And as I said, this talk was given to some of my colleagues down across the country, MS specialist nurses, and it was really looking at the policy and looking at where we align our priorities as nurses who manage long-term conditions. Okay, so it's how we can be better, how we can do our job better in the context of women's health. So this disclaimer at the bottom, it's just there are 3 levels of expert, and like I say, I am no expert in here. My dad always tells me that an expert is either an ordinary man a long way from home, it's anybody from London, or it's an ex being a has-been, and a spurt is a drip under pressure. I always like that little explanation of it, so be wary of anybody who says they are an expert. So MS, here's the facts here, right? It's a disease affecting the central nervous system, okay? So it's where your brain and your spinal cord are. It's every single message that you send and receive is withheld within there. And basically what happens is when there are cells that shouldn't be there get into the central nervous system and cause a reaction. And that reaction is mediated by the immune system. So your immune system is what sort of expels everything, gets rid of intruders. And what happens is there's a fight, there's a big bit of inflammation happens, and when the inflammation goes away, it leaves behind scars. Now that's all sclerosis means. We were talking about lections before. That's all it means is scarring, okay? So it's around about, well, this is 130, the latest numbers that are just about to come out, there's about 145,000 people in the UK are diagnosed with multiple sclerosis. There's about 150 people each week diagnosed. We have really high incidence up here in the northeast of England. There are lots of theories about it, from genes to geography, from marauding Vikings to sexually transmitted diseases, and we think something that the answer lies somewhere within that. Okay, we know that lifestyle and healthy living has a lot to do with it as well. Like we were talking about before, about it has an effect on everything we do. So it's 3 times more common in women than in men. So you can imagine there's 2/3 of my caseload will go through this will go through the menopause at some point. I've already explained most people are diagnosed in their 20s and 30s, but it can be diagnosed much younger, much older, depending on its severity. So younger you are when it's diagnosed, the more likelihood is that you will have disability. If you've got away with things for a long period of time, you find that we pick this up incidentally, and it's on a scan, a brain scan perhaps that you would have for another reason. We could pick that up on an MRI scan. So it's not infectious, it's not contagious, it's not hereditary. We think there is no genetic link or a sequence like cystic fibrosis or breast cancers, things like that. It is, however, more likely within a family, based upon the geography, based upon the lifestyle, based upon the fact that you and your family live the same life, you eat the same foods, like we were talking about vegetarianism, those kinds of things. You were exposed to exactly the same as the rest of your family. So it's a lifelong condition, but it isn't terminal. They say that, it can reduce your lifespan by about 5 years, but that data is really quite old. In the last 25 years, since I've been in MS specifically, we have gone from having no treatments to now really struggling to keep a lid on what treatments are available. Disease-modifying therapies, we call them. And that's another little tricky part of the menopause for women, is that they can cause menopausal symptoms. So it's another thing that people have to navigate. Everybody is so different, because when I said that sort of inflammation can happen anywhere in the central nervous system, and where it lands, we don't know. So the effects that will have on your body, we will never know. Say, for example, it happened in the brain, you're more likely to have visual disturbance. If it happens in the spine, you're more likely to have lower limb involvement. So it's really quite, that's another talk, basically. It's one of those things, and what I will say to you, that in the last 15 years alone, we have had such advances that we are turning the tide. My caseload is now more able than it ever was. There are people that you will walk past during the course of your day who are living with MS. It's not taking over their life, and it is a real sort of, we're starting to get a hold of it, and you can really feel there's a big change in how MS is affecting people. So that's really good, and we know that, as these advances happen, we know fine well that we're getting towards that elusive cure. So it's more likely, we say that the further away from the equator, the more likely you are to have MS. So we know that it's got a vitamin D correlation as well. So vitamin D3 is really, really important. We also have, I've already mentioned the family members there, but vitamin D is one of the things that we now definitely prescribe. Okay?
That's coming out a lot, isn't it? Vitamin D.
Autoimmune, yeah.
Is that because it's helping to sort of bolster the immune system?
Yeah, yeah. And it's all to do with, again, it's like, you know, we know that the closer to the equator you are, the less likely you are to have that. We had a rise in autoimmune disorders over the last sort of 15 years. 16, 17. When did we have the big skin cancer scare? Was it 2002? Where everybody had to wear factor 50, absolutely slathered in block. And we know that there was a rise in it then because
the value of the block.
Absolutely, absolutely. So that's something else that we do say.
With the vitamin D prescription, when we buy them over the counter, the big thing at the minute now, isn't it? And even with children, you have vitamin D deficiency. It's a big thing. Most people have a vitamin D deficiency. So does it matter where your vitamin D comes from? So I buy mine from Aldi. Is that fine?
It's how much you have, and you could argue that Holland and Barrett is going to be a more likely to be absorbed than something you buy off Amazon that's a food supplement from America. Yeah. However, you can't overdose. In principle, you can't overdose on vitamin D3. Okay, what you've got to be careful of is what vitamin D3 does is encourages the absorption of calcium. Yeah. So that's the one thing that we've got to be careful of. 4,000 international units is what we recommend, and I would imagine if you look at your packet when you get home, it's 400.
Right. Yeah.
And we call it international units. 1,000 international units is 25 milligrams. That's a sort of term we understand. But 4,000 is what we recommend. And we do recommend that pregnant women take it whilst they're nursing as well, and then supplementation right the way through their breastfeeding. So that's something that, because my mum had it, I've always supplemented with it, and my children have. I use the spray from Boots, it's 3,000. You don't have problems with absorption because it's absorbed straight. Absolutely, yeah, that's right. So you're not losing a little bit of it. But the majority of the people, I tell people to go onto Amazon, you can get a year's supply for less than £10. Wow. So that's where we advise our patients, because unless you are depleted in this country, you cannot get this prescribed. Some GPs do, but you can't. So unless you're depleted, and then you have to go on to a treatment which is 20,000 units twice a week for 7 weeks, and then go on to a maintenance dose, and then you just stop. If you can supplement over the winter, that's the best time, because you're natural. You step outside in the sun on a lovely sort of crisp sunny morning in your t-shirt, exposed there, you've got 20,000 international units within half an hour. You can't really go wrong with that, so it's just making sure you haven't got that block on. But all of our face cream, all of our makeup now, everything's got SPF in it, so we're blocking our own sort of natural absorption. So that's kind of what MS is. Okay, so the list of symptoms I'm going to come to when I'm talking about the comparator, but we're talking about from top to toe cognitive problems, memory problems, understanding, expression, visual problems, swallowing, speech, problems with sensation, tightness, stiffness, spasms, pain. All of these things can be associated with menopausal symptoms as well. So it's really difficult for us as clinicians. Most of the time we will diagnose on an optic neuritis, okay, so an inflammation of the optic nerve, and most people will be diagnosed when they come to their GP and say, I can't see in my right eye, or I've got blurred vision. But we all know that menopausal symptoms have blurred vision as well. So there's a lot of women in particular don't get I'm making massive sweeping generalisations when I say this because I'm basing it on all of my friends and my experience in. Women tend to roll their sleeves up about most things, particularly if they've had children, because
you have to get on with it.
And you work, everything hurts, everything's an effort. So you kind of just get on with things, and a lot of the symptoms of MS are just put to the back of your mind because you're too busy getting on with life. So there's a lot of diagnoses are actually delayed as a consequence. So can you see that all right? You might have to have a little look, but what it is does menopause affect the course of MS? And the answer is basically no, because we're less likely here, if you can see, pink along the top one is pink and blue, so pink for girls, blue for boys, obviously. It's equivocal in childhood. In puberty, it's more likely to be a female that's diagnosed. In pregnancy, you're sort of less likely to get it, but it's women who will be diagnosed. There's sort of the period just after, about 6 weeks after you've had the baby, you're at more risk of developing MS. The symptoms will come out from months 2 to 7. It's a real sort of risky area. You know, if anybody's had children, when you've had that child and that horrible, the 6-week blues come upon you, and all those beautiful hormones that have been filling your hair full of volume and you full of life and your boobs full of fullness leave you. And as they leave you, that's when MS strikes. It knows that you're low. So that's another sort of risky period postpartum. We feel that you're actually protected. During pregnancy, again, hormonal protection. And then menopause, its prevalence is sort of, you're not diagnosed then. It tends to be during that little middle section of life between 20 and 40-ish. So childhood, this is the relapses. Now a relapse is just an exacerbation of MS, okay? It sometimes is the first thing that we ever see. The optic neuritis, it could be the tingling in the fingers, it could be the loss of the use of the hand or the foot. And that kind of signifies what we call a relapse or an exacerbation, okay? So you're less likely to get these in childhood. You're more likely to get them through puberty. They're almost non-existent during pregnancy, like I said. You're more likely to get them in that danger period, postpartum. And then you're less likely to get them in menopausal times. So it's really important that at that point my colleagues are aware of that, because it's more likely to be menopausal symptoms, not MS. And a lot of GPs blame their MS because that sounds terrible, I don't mean that, it's not something, it's just an easy fix to say, speak to your MS nurse, speak to your neurology team, because I think it could be that. And that's probably down to a lot of perhaps a loss, a lack of information in GP land, as well as, I don't know whether you're privy to, you've all been through your GP service, but at the minute we're working with a lot of locum GPs who are not affiliated with practices. So they come in, they stand in, they do a 2-week period within a GP surgery and then leave. So they've got no sort of it's not loyalty so much, it's more that there's no consequences. They come in, they do their job and then they leave. And the NHS is kind of running on a lot of that at the moment, which is another barrier to people getting treatment. So if you've got
GPs are not trained in menopause.
No.
We are starting to see now that medical students are starting to
They are.
have that information.
Yeah.
And I hope a nursing student have that in their curriculum.
I think what we were terrified about was it's actually optional in GP land, whether you do an optional extra session, and they've got to do that off their own bat as well. It's not something that's part of the GP training, like you say. But like you say, things are changing, it's moving. So the other part of MS, there's 2 parts of it. Okay, there's like the inflammatory bit at the beginning, and then there's the bit that ends with progression. Okay, this is the bit we're seeing less and less of over time because of the disease-modifying therapies. However, it is a huge part of MS, and this is the bit that everybody sees. So as soon as I say MS, most people see a wheelchair or somebody who is using a wheelchair or a walking stick, and that's not necessarily the case. So, but it is still there. So we're less likely to see progression in childhood or puberty, but we are more likely to see progression in the menopausal stage. So, do you know about the vision? Do you know about the right? Okay. So there was the vision for women's health was the strategy for England, and this was not last year, the year before, in December. So it was on the back of it was during COVID. So there was a lot of people worked on this in little silos, and then they came together last year to actually bring it together. So their vision was that there was a call for evidence to develop. This is the first ever women's strategy that's ever been. I think it's since 1990 or something like that, where somebody just did something on the back of the fact packet. It wasn't really anything. So what it was it's essentially to improve the way us as healthcare professionals listen to women. And it was putting your voice, women's voices, at the centre of their own care, but also of every consultation that we do. So it was basically to improve health outcomes of women, but they kind of received 110,000 responses to a public survey. That's not a lot, is it, considering it's half the population? But I don't ever remember being asked for my opinion. I don't know about you. So it wasn't very well publicised. However, just to put that into context, 758,000 nurses in the UK. Where were we? Why didn't we answer this? You know, because we're all quite sort of volatile people, vocal people. We're volatile as well, some of us, but you know, sorry, misworded that one. And 77% of the workforce are female. So why? That just blows my mind that there wasn't.
When they want an NHS survey of how their employers are treating them, we get, for all it's confidential, you get repetitive emails going, how do you
how do they know?
I don't fill it in because I think that's not confidential. If you
No.
to tell me I haven't done it.
Yeah. You know I haven't replied, don't you? I know.
So I haven't had an email to say you haven't done that.
Yeah, so, and that was only 2 years ago. Just over a year ago. So, come on. Is it stuck? It's stuck. I can just flick through it that way if you want.
Try again. Is that where you were?
Yes, it is. Just doesn't want to go past that, does it? I will just do it that way then. Is that all right? Are you sure? Just present from there. We might have to just keep going out. There you go.
Oh, that's where you were, isn't it?
That's right. That's fine. That's.
Is it that one? That's where you were?
Yeah, but I finished that one, so I only. That's it. Right. So. Okay, and we're back. So look, you can see the outcome of the consultation. It was perimenopause, and menopause came out as the top, the most selected topic that we wanted to talk about. Between your obvious age range there, and there was a low confidence throughout. Every person who responded saying they didn't feel as though healthcare professionals listened to them. It just says what we all know, doesn't it? Yeah. And 9% of them felt ill-prepared for what was coming next. And things just happened on them, and nobody talked about it as well. There was a big drive about the lack of healthcare professionals' knowledge, not just GPs and practice nurses, but hospital staff as well, hospital consultants, gynecologists, etc. And the access through GP. It's no surprise to us. This is why this movement is on now. The poor communication in between, not only your hospital to your GP, but from your GP to other sources, really, really poor. So, you know, you would turn up at your GP and say, well, I saw my consultant about this, but there was no letter, there was no evidence of that consultation. Treatment availability, like you were saying before, without a fight. And also, it was not even acknowledged in any SOP that was a standard, operation procedures in any workplace. So it wasn't even, you know, menopause was not even mentioned in workplaces. And considering half the workforce, more than half the workforce is female, that was terrifying information. So, basically, the aims of it now are to sort of take measures to reduce the cost of access, the cost of the drug in the first place, because I'm not going to go into that, because trying to access drugs, we import a lot of ours from overseas, Brexit, blah, 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 blah. Trying to get hold of that has caused huge problems in hospitals. We get a daily alert as to how many drugs aren't available, and we can only provide sort of 7 days worth rather than, I'm sure you've all had problems with that. But we get that daily reminder, and that is an access to treatment that, you know, that is the shortfall of our NHS, unfortunately. There is an establishment of the UK Menopause Task Force on the 3rd of February last year. I'm yet to hear or see anything that's been published from them.
Within the trust I work for, we have a menopause group now. And we are the first trust to be registered menopause friendly.
Excellent.
And every month we have a get together, which is great, virtual get together, because our trust is quite big. Mm-hmm. But your daily work doesn't always allow you to.
No, of course it doesn't.
So it's
no.
Kind of, we'll do it, but
yeah.
But you know,
yeah, you just haven't got time to do it.
If you know, as nurses, we can't go out with that menopause group at 1 o'clock because we've got patients or we've got assessments to do.
I know.
So kind of, you know, we're positively we're moving in the right direction.
Yeah.
You know, and that information's cascaded, and you can, you know, a lot of it's videos we go back to, and then information's always sent out almost daily. You get something from the chair of the menopause group who's sending it out.
That's excellent, it really is.
Really moving forward.
Yeah.
Menopause Day, there was that week, they kind of had lots of things on that week to give us information, so it was good. Okay,
and it was also, quite topically, consider recommendations of the inquiry of the APP on, menopause, which your man infiltrated.
Paul Howell is involved and is vice chair now.
That's, it is for the area, but it is just generally, is it not? That is wonderful. Yeah, that speaks volumes. Yeah, wonderful. I'm just going to skip through this bit because I don't know whether you can see that very well. You might be able to see this on the video a little bit better, but it's just taking you through what the stages of health are. The reproductive health needs, which go through all of the things that we provide in the NHS for women with childbearing potential, people with childbearing potential. And it goes through the first, second, and third, the later years, they call it. I don't like that, the later years. I don't like the word late in anything, really, but that's just me. The general health needs, it goes through what the things like well-being and lifestyle, which is everywhere at the moment, and it is in every thread. It's a theme in everything that we provide in the NHS. Mental health, long-term conditions, which is my bag. And health impacts of violence against women is really on the agenda at the moment as well. But moving further on, osteoporosis and bone health. Again, we're talking about vitamin D3 and dementia and Alzheimer's. The thematic priorities. So NICE guidelines, what we do in healthcare, we have NICE guidelines, and that is what the National Institute of I think it's Clinical Healthcare and Excellence, they provide what is the absolute gold standard, okay, of what you should receive in any element of your care. There's NICE guidance on everything. And then as a consequence of the NICE guidance, there's a quality standard that you can then benchmark your service against. So that's due for publication in August of 2023. So we're 5 months away from that, 6 months away from it. And the quality standard should be out the following February. So that's really exciting stuff. But again, Davina hit in the middle of that and really caused a storm, and everybody wanted in then. So that's why there's so many consultations going on and they continue on. So that's really quite exciting from a sort of an NHS perspective. We've got about it and help women make informed individual decisions.
Keeps going on for any period of time, but I've never worked in such a supportive trust. Whether or not that's because I've got a fantastic manager, I don't know. Who's a woman, I don't know, but.
Is your chief exec female?
No.
No, even better. No. Even better.
We just. So I've just had a period of sick because I had a scalene muscle spasm in my neck, which was horrendous for 3 weeks. Was really, really bad, but I couldn't go into work because I couldn't drive. I literally
couldn't do anything.
I had to have an MRI scan. We didn't know if there was something going on. So even after those 3 days, went back to work and had a back to work interview. Really supportive. Got referred to OC Health. Really supportive. And yeah, I've never worked in such a supportive trust.
Oh, I'm going to be talking to you off camera, obviously. Yeah. I clearly love my trust, but I'm coming to yours.
Yeah, it's very, very supportive.
Wow. It really.
Menopause.
Yeah.
Because I actually rang up last year when I went on sick leave to HR and said, I'm off because of this reason. And I think I was like 4 days into my sickness, but I knew I was going to be off a long time, and said, what are you going to do as a trust to support me? Because at that point I'd started thinking about this group, and they said, actually, we've got somebody who's pulling together a menopause group within the trust, and within a month she started pulling together, and then that started.
Wow.
I think the first one might have been July. So we were really quick in, and as I say, they worked really hard at getting accredited.
Yeah. Is anybody else feeling a little bit jealous right now?
But it just shows how we're moving on.
Yeah, absolutely.
If you're looking after your workforce, then therefore you're looking after your patients.
Of course you are. And it's great leadership. It shows great leadership, doesn't it? So just, I don't know whether you can see that from there. Yeah? MS, menopause, they are, we've got severe pain, we've got fatigue, cramping, spasms, cog fog we call it, it's cognitive fogging, and forgetfulness, expressive dysphasia, which is the inability to think of a word at the right time, or the word's just gone and you sat there thinking, they must think I'm absolutely useless. You're in the middle of a meeting and then it's gone and you just go, oh hell, excuse me, and that's one of the biggest things with MS is just mid-sentence forgetfulness. Visual disturbance, depression, anxiety, irritability, insomnia, dizziness, numbness, a loss of libido, recurrent UTIs, constipation, temperature regulation. Recognise any of that? Exactly. So you can imagine, I've got a lady come in to see me, and she sits and she'll say, oh, this is happening, all of this is happening all of the time, and my GP just won't do anything about it. I then now have the ability to, because once upon a time as well, it actually stated in the British National Formulary that HRT was contraindicated in multiple sclerosis, and it was only 3 years ago that that was taken out. So my patients could not go onto HRT at all, full stop. So now both me and my consultant document the fact that there is no objection to this person going onto HRT for these symptoms. A lot of the symptoms we treat with things that will be your GP might treat you with, you know, such as an antidepressant for flushing. Gabapentin's really good for that, but it also causes weight gain and a little bit of cognitive fogging. So there's a lot of things that do cross over in the treatments that we would trial first, but we try to rule out the menopause before we blame MS. Otherwise, we would be treating MS symptoms on a woman who's menopausal and she's not getting appropriately and adequately treated. So you can see that we've got all of those things there that just pass through. Am I leaving it too long? Is that what it is? Come on. It's done it again. It just doesn't like me. Let's move on. Dum, dum. That's just a repeat of those, the 34 most. Right. So here's the important bit for us, is that we don't treat. We can't possibly. We just guide GPs that they must, or practice nurses that they must do that. We can't be experts in menopause as well as being specialists in multiple sclerosis. So we do tend to use a collaborative approach. And what I do now is I put my patients on a regular follow-up to make sure that the GP has been working with them and the practice nurses are supporting them in a way that's meaningful to that person. That's what I can do, and then that means that my patients feel supported. So I'm acting towards the strategy, I'm working towards the strategy, and I'm making sure that they are supported through that. The holistic support as well. We do a lot of mindfulness, we do a lot of Reiki, Indian head massage. Those are the things that we advise for symptomatic relief for MS, and a lot of those things such as yoga, CBT, all of the things that are recommended by the Menopause Society, we also support. So you can see where it's really quite tricky for a woman who has MS, who is menopausal, to try and pull things apart. My sort of remit is to keep pushing. I had one lady on the phone the other day and she was adamant that this was my MS, it's my MS. So I don't want to talk about the menopause, this is about my MS, this is the MS symptoms, and they weren't. But she couldn't see that because she'd been brainwashed into thinking that it was MS, go see your MS nurse. And it's like, you know, we really need to rule these out because it's easier to do that than it is for us to sort of treat the MS symptoms. So we do the rule outs. We make sure that we rule out all of those things. Oh, right, we are falling out, me and you. Oh, no, there we go. There's quite a lot of studies now, and they're all within the last 3 years of HRT on the symptoms of MS. Again, much like the rest of the world, the menopause has come on the agenda, it's gone into research design, and it's certainly coming out in a lot of clinical trials. So this is worldwide, it's not just UK-wide. There's the Danish registry, we've got, there's work from Spain, there's work from Canada. So it's not just the UK, which is really encouraging that they're actually looking at it as well, and it's not just us. Okay, so the questionnaire was about the impact of HRT, and there's only 19 people, but more than half reported worsenings of symptoms of their MS after the menopause, which is in keeping with our previous slide about what happens with progression. But actually it evened out when they went on HRT. So we knew that it was menopause mediated rather than their MS progressing, with 75% there increasing. So You know, testosterone, I think you two can probably stand up and give the talk about. You love it. I love it. So it's something that's really quite overlooked in neurology. It certainly is, but it was a study on people with MS and how that affected them. So in a study of 10 men with relapsing remitting, testosterone gel improved, and that was with men. It improved their cognition.
That's what improved for me within 2 doses. It was amazing. 2 doses back to me. It's just fantastic.
And can I just ask,
what's this again?
Testosterone.
So I'm on high dose HRT. I'm on the highest dose, and it did take some of the symptoms away. But that brain fog, that low mood, that anxiety, a lot of the symptoms didn't go, and I knew it was I knew.
What made you think it was? Just your research.
Research. When I realised there wasn't enough support for women in this area in this country and in the world, hence the group starting, I wanted to be, you know, they say novice to expert. I wanted to be at the novice part, but I wasn't even on the novice part before I started this journey, so I wanted to be somewhere there. And I just researched everything about HRT, about the body, how it impacts, and about the treatments. And then I'd only ever heard of testosterone because that's what men have. You know what I mean?
Of course, I
didn't know we had that. And the more I researched it, and the more I researched what it does to your body when you don't have it as a woman, and what it can do to your body when you do get given it as a woman, I was just convinced that it's, you know, and I got a little bit obsessed with it. I want testosterone. I don't
think it's a bad thing, you know. And do you think that's influenced your GP for other people? Do you think they would
reduce it? Yeah.
Oh yeah,
I would
that's
say
a long conversation. I only got it prescribed because I was referred to a menopause clinic,
right?
At Darlington Memorial, and after 4 months. I did finally get prescribed it.
And how did you get yourself referred to a menopause clinic?
I just kept going back and asking the question again and again. I don't know how many times I've been to the GP. I've lost count.
Same one, different GPs?
Time, all different GPs. Most of the time I've mentioned, first of all, it was, they wouldn't put me on HRT, they just said, no.
Get on with it.
Did the blood test, did one test, said, no, you're not menopausal. I was scratching my skin.
Yeah.
So I had all the symptoms.
Yeah.
Eventually managed to get that. I've just chipped away at it.
Yeah.
This is the final thing. But I have mentioned it, testosterone to practice nurses. I've read quite extensively on the subject as well. And most of the time I've been looked at as if I've had 2 heads. You know,
that's the sad part of it all, isn't it?
And yeah, so this week I finally got it. So
watch this space.
Yes. Brain fog. For me, it was, for me too.
Because I don't like this person. This is not me. And my other half, we've been together, 7 or 8 years. And when we met, I was doing an MBA. And now, I can't put one foot to the other. I'm a cleaner. Because I'm happy cleaning. And I don't have any pressure or anything. And
you hear that so many ways to women, don't we?
You feel as if you're...
And he lived up here, and I left, would leave in the middle of the night on a Friday night and drive all the way up here, and then go back on Monday morning. And now I don't even want to drive out of the village. Because the anxiety and the palpitations, and I can wake up in the night and I've got this
pounding.
And it's just not like me.
And where are you on your path with your GP?
It's a bit up and down. Depends who you get. The guys are better than the girls. They listen.
Mine were the young males who
yeah. Today I had a brain scan because there's all sorts of, I think it's all collected, and then we went for the results of that today to show that I don't have Alzheimer's. which is lovely to know.
That is an absolute wonderful
But
thing.
you just
Yeah.
I want to know, but then do I really want to know?
Yeah.
You know.
Yeah.
So they thought that I'll get my word.
Big breath.
They thought with the cognitive kind of tests, I was definitely. But when they did the brain scan, there's no sign on the brain scan that there's dementia.
Exactly. Yeah. So with that in mind, when's your next appointment? Because obviously that was just this week, wasn't it?
Today.
Today. So your next appointment with your GP will be a collective of all that. Where do you go next? And like the others have all said, what next? What next? What next? And you've just got to keep pushing and pushing and pushing. One little tip, and I always say this to all my patients, try and get the same. You get a good GP, you see that person, even if it takes weeks to get to see them, you see that person. Because the continuity means that you've got that relationship. Of course.
From especially if they don't know anything. I mean, I bought my GP book on menopause. Read that. And he did, and he went to mind if I said, no, I bought it for you, share it with you, share it with the practice. But it has been, with no testosterone, it's just...
Life-changing. No two ways about it, is there? I'm coming back next month to see how you're doing. So, the alternatives and adjuncts, because we have to, there are some people who are adamant that they're not going to go on to anything. We've got 2 PD nurses in our office. One of them would rip your patch off your body to put on hers, whereas the other one is like, I'm not touching anything unless it's homeopathic. So, everybody's got a different desire and driver, haven't they? So, it's just making sure as healthcare professionals, we've got that information out there for you. We've actually put together a little pack in our department for our patients, and within that there is a slot in menopause advice as well, because of my caseload, it's women of a certain age. The other thing is, what my consultant does not believe recording your FSH, so that's the blood test that would tell you whether you're in perimenopause. We don't push for that, and I'll tell you for why. Because if that result comes back negative or within normal range, that means the GP is just going to say to you, well, you're not, but you've got all the symptoms. Yes. So we don't push for, absolutely. So we could take it every day for 2 weeks and it'd be a different reading. So we don't push for that anymore. So I really would advise people not to push for that test. It's not going to drive your care. It's not going to drive your appropriate care. Yeah.
And when the GP said no, then you don't know where to go.
Where do you go from there?
The door's shut.
100%. Yeah.
Guidelines don't encourage it anyway.
No, they don't, and it's got no driver. So that's kind of where we're at with it. We went through a phase of doing it just to help people out, but then we found that we were doing exactly the reverse, so we stopped.
I had a hysterectomy but kept my ovaries, so I didn't know what was going on.
Right.
So I don't even know where I am on this journey of menopause.
You do?
I'm here.
And your body's telling you, and I think that's the important thing, is to listen to that and listen to your symptoms and be driven by that, and keep going back and making sure that you have that conversation with your GP. Wear them down. Wear them down. Educate, no, you wore down and you educated. It was both.
It was a free talk model, but there might have been some tears of annoyance at the end.
Right.
Maybe when she put the phone down from her, but definitely from me during that last conversation of me just going, really, you've been with me through postnatal depression, do you really want to go through?
Yeah.
Come on, let's get, but I was lucky. I think the group helped drive me. Because I was supported by the group.
Yeah. And you were doing it for the group as well. That's the other thing. If you were sort of leading that charge, if you will. Gosh, how many people who aren't you, who have lost all of that confidence, won't do it?
Yeah.
Or can't do it. It's not won't, they can't.
There's just nowhere to go. If it wasn't, honestly, if it wasn't for you, I think I'd have hung myself by now. I really, really do, because I wasn't getting anywhere.
Yeah.
They weren't listening. And you just feel like, this isn't me. When the real me comes back, you'll really like her.
She's great fun.
I don't really like her.
Yeah.
She's not my
Yeah.
and just coming to these sessions, whatever we talk about, I just know it's a safe place, everybody's going through the same thing. You're not on your own anymore. And thinking, I want to hang myself.
Yeah.
It's horrible.
And if anybody is, I don't know whether you know how you cut and edit this session, but if anybody's out there and watching that and has just heard what one of the members has just said, if there's a reason to come here and join the group, it's that. You are not alone. Don't be alone. There is no reason to be alone.
Absolutely.
There is an absolute fierce support here for you, and you must use it. So, there you go.
It's brilliant. I mean, as a group, we do support each other. We help the group. So Susan's reflexologist down here, and you've come and done some reflexology on everyone. You've given some of your vouchers for your cleaning service. You know, we make sure that we support each other.
Yeah.
So much.
Yeah.
It's fantastic.
It
really has changed my life.
Yeah. It is.
That's testament indeed, isn't it? Right, so I'm not sure on some of these herbal alternatives. Has anybody tried St John's wort?
I have.
And how'd you get on with it?
Marvellous.
Mm-hmm.
I think it's very helpful as a kind of short-term pick-me-up when your mood's low.
Yeah.
It does react with other medication. I think you have to be very, very careful with it. I think for somebody who's not taking anything else, I think it's quite a good option. Short term for somebody with kind of mild or low mood, but not, and that would be the only thing I've ever
mild to moderate, low mood. Yeah.
That's the only time I've encountered it. It actually helps energy levels as well.
It does. It does.
So I do, I do believe in herbal alternatives. They may not be the magic bullet, but they might.
We did homeopathy as part of our nurse training, believe it or not, back when Florrie was on the wards. But it was quite new at the time, and homeopathy, alternative therapies, again as an adjunct to conventional medicine, and reflexology is one of the biggest things that we use in MS for symptomatic relief.
I'd like a conversation.
Yeah. And it is one of the things that we provide in the MS Research and Relief Centre, which we have a few sort of pockets around there. We've got one in Belmont, there's one in, it's predominantly, its HQ is up in Morpeth, but they provide all of those therapies. So, it's a yoga centre and things like that. So, magnesium's another one that we do advise as well.
And I talked to
watch your bowels.
About magnesium. It's really helpful to take some magnesium before bed if you're struggling to get a good night's sleep.
Yeah.
It doesn't work for everybody.
Yeah.
But it is something that can really make a difference.
Yeah, I
to
take
some
mine in the
people.
morning. So
Well, I would say take it before bed.
Yeah. For cramping.
It helps the leg cramps and sort of twitching
Yeah.
as well.
Yeah.
And anybody with fibromyalgia, magnesium can help.
Yeah. And MS. So we advise that as a first line rather than going on to a chemical, hard-hitting, gabapentin, clonazepam, one of the harder drugs.
what dose of the magnesium?
Well, it depends. It really does. About 1,000 is round about where we would say, but you've really got to be careful with your bowels, ladies, because it does relax and it relaxes everything. So just be careful, be mindful, but it's also good if you are a bit constipated. So it's not,
I don't have a problem with it.
Great.
Everything else is going Wrong again.
Yeah, not your bowels are intact. You know, some say that you put that on your status. Strong bowel.
You might really do that magnesium.
With a magnesium chaser. That's you having a fillet, isn't it? Bless you. Right, okay, so there you can say magnesium, you know, you've just said it all, evidence, it doesn't support for hot flushes. However, the sleep, headaches, mood, nighttime spasms and cramping, really useful for. Make sure you do get your high-grade magnesium though. That's one of the things that I would say pay a little bit more for. Certainly go to Holland & Barrett for their advice and guidance on that one. And once you've got that advice and you've got the excipients of the drug, then go and source it cheaper on ZipFit. Okay, other things are available. And as you can see, the global wellness industry, look at that. That's 4.5 trillion US dollars. So we invest in that, and that's kind of where you've got to be really quite careful about what you do go for. And you know, for example, Susan, did you say? Yeah, Susan is somebody who, obviously, she's a practitioner. She's somebody who you would trust in what she would use within that environment, and that's kind of, I would perhaps go to a practitioner about that so that you're guided properly rather than Googling, where should I buy this from? Yeah. Is one of the things that we can actually provide within the NHS and refer onto. I'm not sure on its effectiveness, but it's available and it is something that we do sort of.
There is allegedly some research around early childhood trauma and trauma through pregnancy and birth that links with how a woman can experience menopause. So the CBT can come
lead you through from that. Yeah. There's just not enough practitioners, certainly not in our area. I mean, gosh, Sunderland doesn't even have a health psychologist. We for long-term conditions. We have it for things like diabetes, all the ones that have come through the World Health Organization, you know, coronary heart disease, etc. But for long-term conditions, we don't. Desperately trying to recruit. There's no trained psychologists for it. So, you know, what do we do? For
we had
for anything really.
Someone who I used to work with, who was my manager, he's a trained CBT, and he came and did a talk to us in June, I think it was, June or July, and he's really, really good.
So, and it's getting somebody that, you know, the NHS has broken, more or less, and there's been so many cutbacks, and once somebody leaves, that's the end of that role sometimes. And trying to fill those roles is really, really difficult. So if you do have a practitioner, or if anybody's interested in practicing or training to practice, then that's something that's, you know, they're crying out for at the moment. So my last little bit, and I'm going to stop here because I think I've gone on way too long, is about the change in employment law. And as you've said, you've got this change, this movement within your trust, which is only going to infiltrate the rest of us. But you can see the House of Commons will be a menopause-friendly employer, says the Speaker. Let's watch this space. It's not going to happen, is it? Goodness, exactly, yeah, absolutely. And it starts with places like this. It starts with people like your good self, Catherine, practitioners like yourself, Susan, those people who come to these groups to spread the word, and change comes from within everywhere. And you know, from my perspective, it was Michelle Elliott who, her son went to school with my son, and she just posted something that you'd done last year or the year before, wasn't it? And that's kind of how it's moved. Yeah, it is, and that's infiltrated our office, our consultants, the fact that we were down at the Royal College of Nursing, the Neurology Academy, you know, all of those things have stemmed from that one conversation with a friend.
Wow.
So, you know, those changes come from small acorns, and just I commend you in what you're doing and thank you for it as well. So, I think that's it. So my parting shot is, to all my patients, is find the support. We find the support. We advocate for our patients. We signpost, guide. We don't take no for an answer. Sorry, I'm tapping this as well. Sorry. And just try to make sure that we can make sure we are making a voice for that person. And that's all we can do. And we're doing it one person at a time. So thank you very much.
Thank you.
Okay, and that's it. I think that's it. Thank you. Thank you.